Welcome everybody to the Good Hormone Health webinar today, titled OOO Ozempic, a webinar on Ozempic and other weight loss medicines. And we're also live on Facebook, right? Yes, everybody see us on Facebook?
Okay.
We're all set, Tiffany?
Yeah. Yep, we're all good.
Okay, good. We'll start with a commercial.
Oh. People with type 2 diabetes are excited.
My sister loves this commercial.
Once weekly Ozempic. In a study with Ozempic, a majority of adults lowered their blood sugar and reached an A1C of less than 7 and maintained.
Oh, under 7.
And you may lose weight. In the same one-year study, adults lost on average up to 12 pounds.
Oh, up to 12 pounds.
A 2-year study showed that Ozempic does not increase the risk of major cardiovascular events like heart attack, stroke, or death.
Oh, no increased risk.
Okay,
Ozempic should not be the
so those are the 3 O's.
It does not increase the risk of major
A little bit of background still. Okay, I think everybody's muted. Good. Okay. So with that introduction, we will get started. So the outline of today's talk is to focus on health and wellness. Who should go on weight loss medicines? Which weight loss medications are the best? What are the side effects? How do they work with diet and exercise? How do you get insurance coverage? And then I'd like people that have used Ozempic or Mounjaro or Wegovy to share their experience. They can especially do that on Facebook, but I think they can do it on Zoom also. So my main approach to weight loss is to rule out endocrine problems such as hypothyroidism, Cushing's disease, or growth hormone deficiency. These are 3 conditions I see commonly that lead to weight gain. And simultaneously, I encourage patients to consume a low-calorie diet. I often recommend eating large amounts of vegetables. I like my vegetable revolution diet. Vegetables are low in calories, a lot of nutrition. And I also encourage my patients to move. A lot of exercise is great. Additionally, I encourage my patients to get a good night's sleep, have good mental health, be out in nature, and avoid stress, or at least don't let stress bother you. Patients tell me they've done all that. Many of the patients already have a healthy diet and exercise. Patients need a jump start for the weight loss, and this is where weight loss medicines come into play. And they can also reduce food cravings. A lot of people, especially with endocrine issues, seem to have a lot of food cravings. So I often prescribe weight loss medications after other endocrine conditions are diagnosed or properly treated. In my 2022 Endocrine Society meeting, it was a fascinating talk I went to. It was pointed out that only 2% of patients with obesity are on weight loss medicines. 2%. Imagine if only 2% of patients with diabetes were on diabetes medicines. I think the statistics is like 98% are on diabetes medicines, or 2% of patients with high blood pressure are on anti-hypertension medicines. I think 95% or so of patients with hypertension are on hypertension medicines. So the question is, why not? Why don't people prescribe obesity medicines more? Why don't doctors use them more? First of all, a lot of doctors don't prescribe them. They don't feel comfortable prescribing them. They don't know how to prescribe them. They have this unrealistic view that if obese patients had more willpower, they could just lose weight. The medicines are often quite expensive. And even more importantly, there's a lack of insurance coverage and difficult pre-authorization requirements, which is actually getting worse. And this is quite a bothersome for doctors. It consumes a huge amount of their time. It's getting worse, and there really isn't any checks to prevent this from happening. And then people and doctors are concerned about side effects, rightfully so. So let me talk about the different types of medicines. We're only going to talk about mostly the GLP-1 receptor agonists, but then we'll talk a little bit about the stimulants. The stimulants are related to amphetamine. So therefore, they're a little bit of upper, give you more energy, make you hyper at times. The one I use the most is called phentermine. Another one I use somewhat frequently is called phendimetrazine, tenuate, and there's Cosima, which is a combination of phentermine and Topamax. Now, the GLP-1 receptor agonists we're going to talk mostly about today. These are originally medicines for diabetes. The main one we're going to talk about today is Ozempic. We also have Rybelsus, Wegovy, and Mounjaro. And we're not going to really talk about liraglutide and delaglutide, which are called Victoza, Saxenda, or Trulicity. as they have much less weight loss. There's one called Contrave, which is naltrexone plus bupropion. There's one called Orlistat, or it's also called over-the-counter. It's available as Ali. Doesn't work too well and has a lot of side effects. And there was one called Belvix or lorcaserin, which was removed in the market in 2020 due to increased rates of cancer. Phentermine, I do use it a fair amount, and it's even good if you want to take a holiday from the Ozempic type of medicines. You can go on phentermine. It's also called Adipex P or Suprenza. It was part of the fen with the fenfluramine. The fen with a F was removed from the market due to heart and lung problems in around 2000. The phentermine itself, with the pH, has been in use for 50 years and is safe. There's comes in 15, 30, and 37.5 milligram tablets or capsules. It's about $40 a month for the 37.5 milligram dose. So about a penny a pill, about $1 a month, $1 a day, excuse me. Not too expensive. It's approved for short-term use, sort of in a 2 to 4 month range. It decreases the appetite and may have some increased effects on increased metabolism. It's in the category of amphetamine-like drugs, has common side effects, including hyper, jittery, rapid heartbeat, increased blood pressure, trouble sleeping, and possibly urinary retention. Works pretty well at a low cost. I usually give a half a pill of the phentermine before lunch and dinner, and that's when people eat the most. If someone gets an insomnia, I move it earlier in the day. There's always the caveat: the long-term use is not established. It does seem to wear off with time, as do some of the other medicines. And I usually give this for a period of 2 to 6 months. Phendimetrazine is also called Bontrol. It comes in the immediate release 35 milligrams and the slow release 105 milligrams. It's $32 for 90 capsules of the 35 milligrams, so pretty inexpensive. The SR is also about $1 a pill. It decreases appetite and may have some effects on metabolism. It's also in the family of amphetamine-like drugs. Side effects include dizziness, dry mouth, difficulty sleeping, irritability, nauseousness, vomiting, upset stomach, and diarrhea. The immediate release form is labeled as PDM in reference to the active ingredient phendimetrazine. The 35 milligram tablet is usually prescribed 2 to 3 times a day to be taken 30 to 60 minutes before each meal. The sustained release is taken as a single dose of 105 milligrams once a day, usually 30 to 60 minutes before the morning meal. I use it in patients who have failed phentermine. Also, again, you can use this as a holiday for people on the GLP-1 receptor agonist. And sometimes, but not always, it's hard to find. Just make sure everybody's still muted. So, okay. Tiffy, you make sure everybody's muted on Facebook. It sounds like we have a little bit of background, but.
Yes, everyone is.
Okay, great. Then the next one is called Casima. It's phentermine plus Topamax. It comes in these different doses, including the higher dose of 15 milligrams of phentermine plus 92 milligrams of Topamax. You can see the dose of phentermine is much less than the dose of phentermine by itself. It's $629 a month, so it's a fortune. It's a mixture of phentermine, but phentermine is much less expensive. And which phentermine lowers your appetite, and Topamax, which is used to treat seizures or migraines. The idea is it's supposed to make you feel hungry, less hungry, or fuller sooner. Side effects include constipation, dizziness, dry mouth, taste changes, especially with carbonated beverages, tingling of your hands and feet, trouble sleeping, and people feel stupid on it. So it's affectionately called Stupamax. And I don't use this drug at all. Basically, I don't see any advantages over the phentermine. So let's go into the main topic today. It's called GLP-1 receptor agonist. These are drugs that are called incretins. I'll explain what that means in a second. That's because they've done experiments that when about 50 years ago, they gave oral glucose. It raised people's insulin more than IV glucose. So it was thought there was a factor in the intestine that secretes insulin. Years went by, and this factor, there's 2 of them found. One was called glucagon-like peptide 1, or GLP-1, and one is called gastrointestinal peptide 1, or GIP-1. And these have been, as the years go by, and I'll explain a little bit about the history of this, these have been the basis of the GLP-1 receptor drugs. And they were found to have, there's been found to have GLP-1 receptors in the brain that control appetite. So a lot of the reason why they work is they're intestinal peptides, but when they're given to the body, they bind to the GLP-1 receptors in the brain and cause satiety. So this is an interesting history. I knew some of this before, but there was an article in the Wall Street Journal at the end of June about this. I thought this was really fascinating. So in 1980, researchers at Mass General Hospital wanted to use new technology to find the gene encoding a hormone called glucagon. Glucagon is a hormone that kicks in when you have low blood sugar. And they studied the anglerfish. The anglerfish is shown at the top left there. It's sort of an ugly fish. They have a special organ that makes the hormone, which made it easier to gatherify and purify the tissues. They eventually determined the genetic sequence of glucagon and learned that it was the same gene that encodes related hormones known as peptides. The peptide is encoded, and I was a little bit involved in some of this research in my years at the NIH, my years at Cedars-Sinai. I studied the enzymes that broke down the pro-glucagon molecule to glucagon-like peptide 1, as well as glucagon. The glucagon-like peptide 1 is nicknamed GLP-1. Scientists in Massachusetts and Europe learned that it encourages insulin release and lowers blood sugar. So they hoped this could be used to treat diabetes. There was also some thought that patients with diabetes had high levels of GLP-1, but then the more later studies showed they have low levels of GLP-1. So it was sort of thought that this could be a good target for diabetes. And they felt that the GLP-1 makes people feel fuller, slows down the emptying of food from the stomach. But there's a problem. The GLP-1 vanishes from the body as fast as it's secreted. It's digested by enzymes. The main one is called DPP-4. There's a drug that blocks the enzyme also, called Januvia. And then it gets washed away in the kidneys in minutes. So there was little chance of developing this peptide into a drug. However, as the years go by, scientists turn to the Gila monster, which is shown in the lower left, sort of an ugly creature, although I think it's sort of cute. These are animals that are found mostly in the Southwest United States, mostly in Arizona. I think there's even a city called Gila or Gila, Arizona. And the Gila monster only eats maybe 4 times a year. I heard twice a year, but this article said 4 times a year. And they don't get high blood sugar or low blood sugar. It keeps them full for these, every 3 months when they eat. They maybe eat a rabbit or a rat or a mouse or something like that. And they're able to keep their blood sugar pretty constant because they have an endogenous GLP-1. They live most of their lives below the ground. They slowly digest energy stored in their tails. So 2 people studied the Gila monster venom they ordered from the Miami Serpentarium, whose owner survived 172 snake bites over the years as they produced venom for the research. One of the doctors, Dr. Ang, isolated a small peptide that was called Exendin-4. It was very similar to GLP-1, so it was very exciting. However, the advantage of the Exendin-4 is it doesn't get broken down by those enzymes. They gave it to diabetic mice, and they found that it reduced blood sugar, and it did so for hours. It lasted a long time. The mice and eventually the people got side effects. A famous researcher, David Nathan, was a Massachusetts general physician scientist who led the 1991 study. He still remembers what happened when they increased the dose to humans. One person leaned over the side of his chair and threw up on my shoes. However, this led people to use this drug from the Gila monster, the chemical sequence of that, to make a peptide. And that peptide was called Exendin, and its brand name was called Byetta, or Bydurion. And the FDA approved this in 2005. And I remember when it came out, it was sort of exciting. I used a fair amount of it in my patients at the beginning. It didn't work too well either. It was twice a day shot, and it gave people sort of welts where they got their injection. But, it was okay, and people lost a little bit of weight on it. Eventually, Novo Nordisk got into this business. Lilly got into this business. And they made new drugs that were related to the Exendin and modified the peptide so it lasts even longer. So the drug called liraglutide would get FDA approval in 2010. And that was a drug, again, GLP-1 receptor agonist, lasted a longer time, once a day drug, worked reasonably well. However, as the years go by, people tweaked the molecule more, and 7 years later, which is in the, so this was in 2010. So in 2016 or 2017, the drug semaglutide was approved. That became Ozempic. And first it was used, and I think it's a game-changing medicine, basically. I think this is, when I think about the advances in our medical society, I think this is near one of the top game-changing medicines. In 2021, 2017, it was used to treat diabetes. In 2021, the great drug called Wegovy came out and was used to treat obesity. So you have Ozempic for diabetes, Wegovy for obesity. So how do these GLP-1 receptors work? In hyperglycemic states, when the glucose is high, these GLP-1 agonists stimulate insulin secretion and they delay gastric emptying. So this is that so-called incretin effect, the effect in the intestine, and it slows down your emptying, so your food stays in your stomach longer, you feel fuller. It gives you more insulin, so that helps with diabetes. In euglycemic states, it suppresses your glucagon, so you don't get this counter-regulatory effect and your glucagon doesn't go up. And most importantly, it decreases your appetite, and that all those things result in reduced body weight. There's a little schema of it here. The GLP-1 is secreted upon ingestion of food from your intestine, unless you take it as a pill. It increases the beta cell in your pancreas to make more insulin, so it enhances glucose-dependent insulin secretion. It promotes satiety, reduces appetite in the brain. It's one of the key things. The alpha cells are the cells in the beta in the islet of the pancreas. It decreases postprandial glucagon secretion. In the liver, it decreases hepatic glucose output, so you have glucose coming from your liver. And most importantly, or equally importantly, it helps reduce gastric emptying, and that slows down your intestine and makes you feel full. All these work to both treat diabetes and treat obesity. So semaglutide, or also called Ozempic, is a diabetes medicine that leads to profound sustained weight loss. It is not an amphetamine-like drug, so patients who have side effects on something like phentermine or phendimetrazine can often tolerate the Ozempic quite well. The main side effect of the Ozempic is nauseousness and feeling full. Those happen in a good portion of the people. So you need to go gradually on the dose of Ozempic. We'll talk about that in the next slide. But basically, I have people start at 0.25 milligrams weekly for a month. And then we usually do 0.5 milligrams weekly for 6 weeks. And then we go up to 1 milligram weekly. And then you can go up to 2 milligram dose, as it's recently been improved. And you can get some additional weight loss and diabetes effects. Some people do fine on the lower dose. They don't need to go up, So I think you should ride out the lower dose for the most part if you're losing weight and you feel full on it. And then when that subsides, you can go up to the higher dose. If you go from the 1 milligram to 2 milligram dose, I recommend the first 2 doses of the 2 milligram dose every 10 days instead of every week. If you do get nauseousness, and I'll talk a little more about clicks on the next slide, but you can go down to 0.25 milligrams a week if you're on the 0.5, for example. If you're on the 1 milligram dose, you can go down to the 0.5 milligram dose. And we can also give you the Zofran, which goes under your tongue, and that helps with nauseousness. Now, my good colleague Ann Peters at USC taught me about the clicks. And I think the clicks are really a cool thing to do. It's only available in Ozempic. Wegovy or Mounjaro don't have clicks. Only Ozempic does. 18 clicks is 0.25 milligrams. So if you develop nauseousness on the 0.25 milligrams, that's 18 clicks. You could go down till you could stop it, nauseousness resolve, and start at 5 clicks or 8 clicks. And then you go up by 5 clicks every 2 weeks as tolerated until you're up back to the 18 clicks or the 0.25 milligrams. In general, the weight loss is greater at higher doses, but the side effects include vomiting, diarrhea, constipation, feeling full, nauseousness. They're also higher at the higher doses. The Ozempic lowers your hemoglobin A1C, your average blood sugar, but it doesn't give you hypoglycemia. So if your A1C is already low, you don't have to worry about getting hypoglycemia on it. It just basically works if the A1C is high. It very importantly, has cardioprotective effects. It helps prevent heart attacks, which is very important in people with diabetes. It has renal protective effects, which is also important with people with diabetes. Helps protect your kidneys, improves polycystic ovarian syndrome, and helps with fatty liver disease. Usually doesn't give low blood sugars. The side effects include nauseousness, feeling full, vomiting, feeling like food stuck in your chest, abdominal pain, loss of appetite, diarrhea, and constipation. So there's 3 different cartridges here. There's the red cartridge, which is it's a silly name. It's called the 0.25 or the 0.5 milligram dose. There's 2 milligrams per 3 mils in the cartridge here. You start at this dose here for 4 weeks, the 0.25 milligrams. You can stay on the same cartridge and go up to the 0.5 milligrams. And usually I have people take that for 6 weeks, and that uses up 2 cartridges. So we'll order the 2 of the 0.25 or the 0.5 milligram cartridge, 2 milligrams per 3 mils, and that's the red label pen. Take the 0.25 milligrams for 4 weeks, and then go to the 0.5 milligrams for 6 weeks. This will use up 2 of the pens of the 2 milligrams for 3 mil pens and last about 2.5 months. Then you can go to the 1 milligram dose. The 1 milligram dose is a blue pen. So you can see here it's blue. It has a blue label, and it says 1 milligram on it. We'll usually order 3 of the 1 milligram doses. These each cartridge lasts a month. So this will last weekly for 3 months. I usually have people schedule an appointment after 3 months or so. We can sort of get them up to this 1 milligram dose and see how they're doing on and see about side effects and things like that. After being on the 3 milligram dose for a month, the 1 milligram dose for a month, you can go up to the 2 milligram dose, which is the brown label pen. You can see it over here. It's sort of a brownish label. And that will last about 3 months if we order 3 of those as well. So the 2 milligram dose has the higher dose per milligram, 8 milligrams per 3 mils. The clicks would be half the amount of clicks. So instead of 18 clicks for 0.25 milligrams, it's 18 clicks for 0.5 milligrams. So people can stay on the 2 milligram maintenance dose. It can be used with or without meals. You inject once a week, usually the same day of the week. People do it on Sundays. It's not the same as insulin. Doesn't cause low blood sugar, can reduce weight, it reduces the risk of heart, liver, and kidney disease. Basically, I encourage people to inject it in their abdomen, although you can also do it thigh and upper arm. Don't inject it into muscle or vein. You can change or rotate the size of your injection. If you're having side effects, don't increase your dose and notify your provider. You should store these in the refrigerator also. They come usually in a cool pack. Keep them in the refrigerator, though if they're out of the refrigerator, it's not that important. But it's an expensive medicine. So the first important thing people should do is check with their insurance and see if it's covered. Ozempic is the one used for diabetes, and Wegovy is the one used for weight loss, and see what the approval process is. Insurance companies vary in their coverage, and they're getting more strict about the coverage because it's an expensive medicine, and they try not to cover it. Other insurances cover it okay. Some of them, this is a new trick they're playing, is they want you to go on a less expensive GLP-1 receptor agonist, like Trulicity or Victoza before Ozempic. And then if you have to fail them. So this is another way they try to save money on that. Sometimes we do that, and sometimes we just try to argue with them a little bit. We'll do one pre-auth for these medicines, but we can't really afford to battle these insurance companies. It just takes too much time. And usually they have their rules, and if you don't follow the rules, you basically don't get it. Another option is to get it from Canadian pharmacies. So I think a Canadian pharmacy might be $300 a month. The non-insurance cost is at least $1,000 a month in the United States. There is some pharmacies that I've heard of, I haven't used any yet, that compound it, compounding pharmacies, but I'm not really too experienced with how they are, so I really don't recommend that right now, but I'll look into that as the time goes by. Now, the most important question is, what about long-term side effects? It's really unknown. These drugs have not been out that long, but as the years go by, at least the Ozempic's been out since I think 2016 or 2017. So it's a little well known. There's a history of weight loss medicines were found to have long-term side effects and pulled from the market. The fen with FEN as part of fen was pulled, Locarsin, and another one called Sibutramide were all found to have side effects and pulled from the market. I don't think this is going to happen with Ozempic, but I'm not 100% sure. In rats, it causes a rare type of thyroid cancer called medullary thyroid cancer. So there's a warning on the label. Don't give it to people with medullary thyroid cancer. Those people are super, super rare. It's a rare disease. 99.9% of thyroid cancer is not medullary. So this is usually not a relevant issue. However, there's a few studies that are coming out now that are called meta-analysis. They pull other studies together, and there might be a slight increase in the garden variety of papillary thyroid cancer. Increase. I don't think this is a concern. I don't recommend getting ultrasounds or monitoring it to prevent it. But there are it's a caveat that there might be some concern with this medicine. So I really recommend only taking Ozempic if you need it. So semaglutide is also called Wegovy. This is a little tricky. Wegovy and Ozempic are the same drugs, but they have a different cartridge. And the Wegovy is approved for weight loss. The Ozempic is approved for diabetes. The Wegovy comes in 0.25, 0.5, 1 milligram, 1.7 milligrams, and 2.4 milligram pens. It does not allow partial dosing or clicks. You give it all or none. You should stay on the same dose for at least a month and then only go up if you're not experiencing side effect. There's a shortage of these medications, including different doses at different times. For a while, there was a shortage of the starting dose, and then I think now many doses are shortage. but many pharmacies have it. So you need to call around to different pharmacies, check with your mail order pharmacy, check with your local pharmacy, check with some smaller pharmacies, and see if you have it. Its side effects are similar to that of Ozempic. There's another one called Rybelsus. They're also the same medicine. It's also semaglutide. Rybelsus is an oral pill. It comes in 7 and 14 milligrams. It's approved for diabetes, and it gives less weight loss, although some weight loss than Ozempic. I think originally people were concerned that people wouldn't want to give themselves a shot, but the shot's really easy. It's a small needle. Most people don't mind the shot. So I know there's not that much of a role for the Rybelsus. You should stay on the same dose for a month and only go up if you're not experiencing side effects. Side effects are like Ozempic, and I rarely prescribe it. Now, the new one on the market that's been around for a little more than a year is a very exciting drug. It's probably going to be the biggest selling drug of all time. It could be. It's made by Eli Lilly, and it's called Mounjaro. The generic name is tirzepatide. It's called a dual incretin. It has the GLP-1 and the GIP, and we talked about both of those are hormones made in the intestine that do slow down your gastric emptying, give you some satiety, and lower your appetite and improve your diabetes. So the two of them work together, and it's even thought that I thought at least the GLP-1 would be the main one. It seems like the GIP-1 has a very important role in this the effects of this medicine. It is not approved for weight loss, and it also hasn't been found to have cardioprotective effects such as the Ozempic does. But it probably will end up doing that. I'm pretty convinced it will, and I think it probably will be approved for weight loss also. It has very impressive weight loss properties, more so even, I'll show you on the next slide, than the Ozempic. On the highest dose, people can lose up to 25 pounds. It's given once a week like Ozempic, has similar side effects, including nauseousness, diarrhea, decreased appetite, vomiting, constipation, indigestion, and abdominal pain. I think it has about the same amount of side effects as Ozempic, not really more, not really less. And some people can have side effects on Mounjaro and not on Ozempic, and some people the other way around. The doses are 2.5, 5, 7.5, 10, 12.5, and 15 milligram doses. You should stay on the same dose as for 4 weeks and only go up to the higher dose if there's no side effects present. And again, some patients do fine on the lower dose, even more so, I think, than the Ozempic. Some people can stay on the 2.5 milligrams. I was just in contact with a patient who did well and lost a lot of weight on the 2.5, had some side effects on the 5, a lot of side effects on the 7.5. So I put her back on the 2.5 milligram dose. She was doing well on that, losing weight. Some patients, many patients do fine on the lower dose. There is a coupon, but the coupon is less beneficial than it used to be. It used to be like you didn't have to check with your insurance. It was just paid the coupon. Now you have to check with your insurance. There's different coverage rates depending on what your insurance covers, but it could be quite helpful. It can be as low as $25 for 3 months, but it's usually not quite so low. So check on the Mounjaro.com. So tirzepatide is a twin incretin. It is a dual GIP-1 and GLP-1 receptor agonist that is used for treating diabetes. It lowers your blood sugar. And this is a paper, we don't have to go over it that much in depth, but you can see over here in B, the weight loss. You have the first one, the open circle, those dark circles here, of semaglutide 1 milligram dose. The patients lost 6.2 kilograms, which is about 15 pounds or so, 6.7%. Then the next one over here is the Mounjaro at 5 milligrams. Then you have Mounjaro at 10 milligrams. And then you have Mounjaro at 15 milligrams, the maximum dose. At the maximum dose, they lost 12.4 kilograms, which is about 30 pounds, 13% of their body weight. It's quite impressive. The people that lost 5% of their weight, let's say that was your target, with the 15 milligram dose, 80% lost at least their target of, let's say, 5% loss. 10% loss was 57 with the highest dose of Mounjaro. All these seem to be better with Mounjaro compared to Ozempic. Their triglycerides got better on the highest dose. Their cholesterol got better. The HDL, their LDL, their VLDL, their HDL actually improved. The LDL got worse. All these, the LDL got better and the HDL got lower and got higher, and high is actually good. The LDL got lower and lower is actually good. So this had very beneficial effects on people's lipids as well. So the important question, I think, is in this day of insurance ruling the medicine, you got to call up your insurance company to see if they cover these. Some don't cover them at all. Some have criteria. Some of you have to have diabetes. Some you don't have to have diabetes. Some you have to do a form. Well, all of them you have to do a form, basically. Some of the form just says, is this worthwhile? Some of them have to say, what different criteria. We'll try our best to complete these forms for you, but it's sometimes it's hard to do it. I think most of the time we get them covered, but not all the time. I don't really recommend face-to-face appeals. It's usually unlikely to be beneficial. So how long do you stay on these medications? Until you get side effects, until you're at your ideal weight. So somebody's 200 pounds, they want to get to 140, they get to 140, they can stay there and go on a lower dose. For phentermine, it stops working in 3 to 6 months. You can take a holiday. Most weight loss medicines, you have some rebound when you stop the medicine. The same with these Ozempic and Mounjaro. Some studies suggest that people, when they stop it completely, gain about half their weight back. So at least they still lose half their weight, but they gain it back half of it. These medicines are often need to be given long term. They're expensive. Long term, we're concerned more about their side effects. What do you do when an Ozempic stops working? I think one thing you do is push the diet and exercise, take a break for a month and restart it, go on phentermine for a month and then go back on the Ozempic, or see if your insurance covers Mounjaro. How do these work with diet and exercise? In general, these weight loss medicines curb your appetite, so you put less toxic foods in your body. I think people eat a lot of toxic foods. Food is expensive. It's time consuming to eat it. It's time consuming to shop for it. So if you can eat less foods, you'll do better. It allows you to jumpstart your diet, decreases cravings, decreases insulin resistance. Usually people feel better on these medicines. Their energy goes up. Some is the weight loss, but in general, there's less inflammation. It's easier for them to exercise. Probably changes their microbiome in their intestines, give them better gut health. So all these are sort of beneficial things of the medicine. What is the Ozempic diet? I saw this also in the Wall Street Journal, among other places. Ozempic can result in loss of muscle mass, so consume a fair amount of protein. Try to reduce your carbs and go on a low-carb diet. Take advantage of this decrease in food cravings, because I think a lot of people crave carbs. When they don't have those food cravings, they eat less of the carbs. Really try to eat clean. Okay, so that concludes the main part of the talk. We will have people can either go on the chat or unmute themselves and ask some questions or give their experience. I think a lot of my patients that are on the calls and on the Facebook today have been on Ozempic, so people can now chime in with either questions or their experience with it. Questions or comments or experience? So Sarah asked, what could be the reason behind Mounjaro not causing any weight even with higher doses? So these medicines don't work on everybody. Some people, just whatever it is, their chemistry, they don't work that well, In general, I think the Mounjaro can work a little bit better than the Ozempic in some people, but some people, they just don't work. Some people may do better on a medicine like phentermine than Mounjaro or Wegovy. A lot of people have the side effects. They can't tolerate the higher dose, but the studies are showing that most people do lose weight on these. Janet asked, what's the target A1C? So I think in general, the target A1C for most people is like 7 or a little less. If you're older and have a lot of other medical problems, it might be a little bit higher. If you're younger, it might be a little lower, but I think less than 7 is good, maybe even less than 6.5. Warren asks, is there any credibility to berberine as a natural effective Ozempic alternative? Berberine gives much less weight loss than Ozempic does. It does lower your blood sugars for people with mild elevated blood sugars, but not nearly as much as Ozempic. I like berberine for a lot of my patients, but it's not Ozempic. Preston asks, are any thoughts on the prescription dose orlistat? So orlistat, I didn't conclude in my talk here. I did in my last year's talk. But orlistat is an oral medicine that basically gets you to secrete fat in your stool. People get like oily stool from it, smells bad. It usually people don't like it too much. The prescription dose, I think, is 100 something. It's 3 times the dose of the regular. The regular dose, the oral, the over-the-counter dose is 36. The prescription dose, I think, is about 116 or so. It works a little bit. I wouldn't have that as my top choice. Nicole asks, is it safe to say on maintenance dose of Ozempic to avoid weight regain? I think so. So I think that's what I recommend is people go on a lower dose for weight maintenance, and you need to stay on that forever, it seems like. Otherwise, most people gain their weight back. Sarah asks, is it true that if you have Cushing's disease, weight loss medicines won't work? I don't think so. That's true at all. I find these patients work very well in my Cushing's patients. I use it in conjunction with giving people medicine like ketoconazole or Isturisa, but I find the Cushing's patients probably do better on these medicines than you might expect. And my guess is it probably lowers your cortisol some, but I haven't done any studies on that. Janet asked, why do these medicines help with PCOS? So they help with insulin resistance. A lot of insulin resistance is key, part and parcel of PCOS. They seem to lower your testosterone a little bit, improving the insulin resistance is the key. How do these drugs affect hypothyroid treatment with unithyroid? In general, they don't affect it. The only thing is if somebody loses a lot of weight, they may need a little less thyroid medicine because the thyroid medicine is usually dosed based on your body weight. Tammy asks, I used Cosima for over a year. The highest dose was not affected at all. I just began Ozempic to lower the weight loss and to lower A1C will be more effective. I think it will. I think, again, these medicines are better than the phentermine type of drugs or the Topamax type of drugs. And can it be used with low dose naltrexone? It can. I don't think low dose naltrexone gives you much weight loss either, but you can use them together, certainly. Mark asks, why do endocrine disorders cause intense food cravings? That's a great question. So some of it has to do with brain hormones. And, just like these medicines may decrease your GLP-1 receptor binding, GLP-1 binding to the GLP-1 receptors in the brain. Some people maybe with endocrine issues like Cushing's may have more binding of that. There's other satiety hormones that might be less in endocrine conditions and more hormones that causes you to eat more in diseases like Cushing's or hypothyroidism untreated. Jamie asks, I've read that Ozempic helps with curbing compulsive behaviors like biting your nails behind food. Have your patients reported any behavioral changes? I probably noticed on myself. So there's a lot of interest in using Ozempic type of medicines for addictions, including smoking cessation, gambling. I think there's some studies on. It's a very promising area, probably, methamphetamine and opiate addiction, it seems to be promising. So I think that's an area, key word, and I do some of my research in that area also. We're probably going to try to investigate some of that. So I think that is very promising. Is glucagon an endocrine hormone? Yes, so glucagon is not under the control of the pituitary. It's made in the alpha cells of the pancreas. It usually kicks in when you have low blood sugar levels, and it causes you to raise up your blood sugar, which can be detrimental. There are these, what's called Mounjaro is a dual incretin. It has GLP-1 and GIP-1. There's about 38 drugs on the investigation that are similar to these medicines, all with some variation on them. Some of them have glucagon in them. So someone has a tri-incretin that includes glucagon. To me, that seems like it would be worse because glucagon raises your blood sugar, but there's other things about it that seems to be helpful, including some of the weight loss properties. It's not under control of the pituitary. Denise asks, will Ozempic or Mounjaro be better for some who has diabetes and also has gastroparesis? No. So if you have gastroparesis, you don't want to take these medicines. Gastroparesis is when your stomach's slow emptying, and these medicines make that worse. So I would say that's one of the contraindications, along with, maybe recurrent pancreatitis, gallbladder disease, where you don't want to take these medicines. What tips can I give my PCP to get my insurance to cover it? So your PCP, he or she just has to order do the pre-authorization, and you have to check with your insurance. What is the pre-authorization needed for this? It varies with the insurance companies. Betsy asked, couldn't tolerate Mounjaro at 2.5 milligrams, had nausea and severe abdominal pain, burning esophagus, headache, and had to stay in bed all day. Couldn't eat at all. Itchy white spots appear on my legs. Does this sound like an allergy? It sounds like a side effect from it. You might want to try the Ozempic at like 5 clicks a week. I probably wouldn't go back on the Mounjaro though. And there's a possibility that you're not going to tolerate the Ozempic if you did so poorly on the Mounjaro.
Okay, I have some Facebook questions.
Okay. Can you share your screen and so we can see them?
I can try.
I could stop sharing mine.
I don't think I can because it'll stop sharing this Facebook. Here, I can go like this. 1 second.
Okay, I'll stop sharing.
To answer that question.
Amy asked, do these drugs contraindicate with other medicines? Probably not. I think they're probably okay with other medications. I haven't heard of any major problems. You know, one of the things is if you're on a diabetes medicine, you may have to cut down on your other diabetes medicines because you don't, or at least you may not need them anymore. Let's put it that way. I think you could still take it, but you may not need your other medicines. As you drop your weight, you may not need your blood pressure pills.
Mhm. I'm having trouble with
This sounds interesting.
So here's a question.
Okay, I can see that. Good.
Okay.
What if I can't tolerate Zofran to deal with the nauseousness? You probably need to go down on your dose. You know, the Zofran works pretty well. But you know, if you don't tolerate the Zofran, probably you need the lower dose. I've had success with Wegovy, then I had to switch to Ozempic. Haven't lost any since switching to Ozempic. I'm sure it doesn't cover Mounjaro. Would it be beneficial to add phentermine daily, or is that not recommended? You know, in general, most of the time, people don't add phentermine to weight loss medicine. They GLP-1 receptor agonist. But I think in theory you could, or you can either do that, like alternate 1 month of phentermine and 1 month of you know, Wegovy or Ozempic type of medicine. I am on 2.
Wait,
Go back up to
this one.
My daughter is
first.
16 years old and had a pituitary tumor. She's currently on Wegovy, although the low dose is out of stock and she hasn't been on it for a few months. We use it for her because it helps her feeling full, not overeating. She did Saxenda previously, but we didn't see the best results with that. Is Ozempic approved for children? I think it has just been approved for children. I think it's 18 or less. I'm not 100% sure. I don't treat that many kids. It is a better drug than Saxenda probably though. So she might do better on it. Go back up a little bit. I think we skipped
Yeah.
Abby's. She's on 2.5 milligrams of Mounjaro. Notice that I'm more sleepy than the first 2 days. The first 2 days after the injection. Is that likely side? Yes, it's likely side. Most of the side effects get better with time. You can sort of write it out. It's better. And again, the Mounjaro, unfortunately, you can't do clicks. You can try to spread it out a little bit, maybe 10 days, but it seems like it's right after the dose. I think you'll just have to write that out. Lisa asked, for those of us without adrenals, do you recommend increasing hydrocortisone dose? Probably not. I think you might even, I think you probably will be okay. I did mention that it might decrease your cortisol, but I don't think it affects when you take exogenous cortisol. But you have to watch out, you know, the side effect is nauseousness, which is the same side effect as adrenal insufficiency.
Mm-hmm.
Jenny says, have prescribed Wegovy to your patient. Have you prescribed Wegovy to your patient with hypothalamic hyperphagia due to cranial pharyngioma? What's your experience? Yeah, I think we have. I think that works. It works well in them. You know, there's a paper by one of my patients who used naltrexone, high dose naltrexone, plus what's it called? Oxytocin, and that seemed to help a lot of the hyperphagia from obesity. But I think Ozempic would be a good choice.
Okay, that's it for now.
Okay, we got some more back on here. I've read that Ozempic helps with curbing compulsive behaviors like biting your nails. We talked about that one. Is glucagon a hormone? We talked about that one. With PCOS and an A1C that is healthy, how much weight loss should be expected with Mounjaro? Began with PC, you could still lose a lot of weight on it, even for A1C or you have PCOS. You could still lose a lot of weight on it. I think especially as you go up on the dose, people could lose up to maybe 30 pounds or so. Can people without a gallbladder take tirzepatide or Ozempic? I think they could, but I would probably start slowly and really watch out for the nauseousness. Deborah asks, is there a certain amount of being overweight that qualifies one to be on these medicines? Yes. So the insurance companies varies with this. Some of them may give you, may say you have to be at a certain BMI, and some of them don't say that. You have to just check with your insurance company.
I don't know if we got to, do these drugs contradict with other medications?
Yeah, we answered that one. It's probably
Oh,
no.
okay.
They're probably okay. Any other people want to share some of their experiences? How many people do we have on Facebook?
Like over 100.
Really? Great. Okay.
Mhm.
We've gotten more questions on Zoom, even though we have less people.
Yeah, right.
Okay, so this will be, let me go back to my slides again.
Mhm.
So the talk will be posted on goodhormonehealth.com in probably a couple of days or so. And you can email us at mail@goodhormonehealth.com for an appointment. In general, as I said, I'd like to exclude endocrine conditions first before giving this, but I'm happy to consider this in patients with who would benefit from it.
Mhm. We just have 2 more questions.
Mhm.
Amy said, will you have any other updates on these drugs?
Yeah, so as the years go by, as the months go by, we may do another webinar, certainly. I think there'll be new drugs out. Prices may drop as new drugs come out. Not sure. The price of these have gone up since sort of the Mounjaro's gone. It came into market. The price of Ozempic has gone up, not down. But yeah, we'll definitely keep people posted.
Mhm. Someone asked, which of the 3 medications do you prefer?
I think it depends. First of all, if you're insured, the obvious question is whatever your insurance covers. I think Mounjaro gives you a little more weight loss than the others. The Ozempic, I like the clicks because then you can, go up slowly and start at a lower dose.
Molly asked, does Mounjaro cause dehydration?
Only if you get diarrhea on it. I think in general, people don't get too much dehydration. They feel full. They might not drink as much or eat as much. Which one is easier to get insurance? It depends on your insurance. Each insurance is different. And some it might be hard on all, some of your insurance may cover all of them. Okay, we'll see everybody later. Thank you.
Okay, thank you so much, Dr. Friedman.
Bye-bye, everybody.
Thank you.